didn't bring any farm animals, but I should have brought the blossom I just picked from my garden. It was beautiful, but it's
definitely next time.
Sorry to hub members. I just submitted this case about an hour ago. I saw this last Thursday, and to be honest with you, I just remembered today that I wanted to submit him because it was kind of an odd case. So this was, if you scroll down to the general, that's good. So this was a 64-year-old man who self-referred to our program. He told me last Thursday that he had been prescribed Percocet for many years, for about 20 years. We're about to get a big thunderstorm, by the way. I hope it doesn't knock my internet out, but if so, say la vie. And he, after being on Percocet for a long time for chronic pain related to work injuries, he decided he was addicted and he wanted to go off it. And he went to a Suboxone program, I believe in Raleigh County here. You know, I realized after he left, I had a big gap in my history, which was, I don't really know how long he was on Suboxone and why he stopped it, but he eventually stopped it. So apologies for the gap. I don't have any explanation for that, except for I think I was just so perplexed by his whole situation that I overlooked that. So he was on Suboxone and successfully got off Percocet. I don't know why he stopped the Suboxone, but sometime since then, he started using Tramadol, buying it on the street. He says he takes about 100 milligrams to 150 milligrams a day with whatever he can get. And now he feels like he's addicted to that. And so he'd like to go back to the Suboxone. Interestingly, when he was on Suboxone before, he went to NA and found that useful. He hadn't been going since then. But at any rate, he also, the other very thing that made this sort of complex for me was that he also takes Ativan, which he buys on the street. He has anxiety disorder and he has been prescribed medications for anxiety and depression in the past. It's also not clear to me why he said he just stopped taking his medicines that were prescribed in the past. He didn't really explain that. And I didn't explore that more, but so he's been taking what he can get on the street. And he says he doesn't necessarily take it every day, but he said sometimes he takes up to 1 milligram 3 times a day. Sometimes it's a half a milligram. He said he hadn't taken any since 2 days before he was seeing me, the day he saw me. He previously had been prescribed Ativan and weaned himself off it, he said. And again, he doesn't like being on it, so he wanted to come off that, and he was under the impression that the Suboxone would help him come off that, which, you know, obviously does not. But at any rate, so those were his reasons for wanting to enter our program, and I talked to him about the fact that I feel that his case is a little bit unusual. You could stay right there for a sec there, Elizabeth. Thank you. For one thing, Suboxone for Tramadol seemed like an unusual indication. He was not asking for Suboxone for pain. He was asking for it because he is addicted to the Tramadol. And also the complicating factor that I wouldn't prescribe it for him if he were going to continue to take Ativan, but he wanted to come off the Ativan. Also the fact that the Suboxone doesn't help him come off the Ativan, and coming off it can be its own withdrawal and dangerous. He was aware of all this and felt really confident that he could come off it, that he wasn't taking it every day, that he just needed to get back on the Suboxone and get rid of those other 2 medications. And he was very clear on this with himself. He lives with his wife who doesn't have substance use disorder and is aware of his use and supports him. He's been disabled for many years from work injuries. And then the other complicating factor is that he has been being prescribed gabapentin 300 milligrams, I believe 3 times a day by his primary care provider to help with his chronic pain. But he says that he doesn't take it. He gets the prescription and he says he doesn't take it because it doesn't work. And the Board of Pharmacy confirmed that he picks up the prescription, which was interesting. So if you could scroll down to those comorbidities. So I actually picked this up more from his medical record, even though he doesn't see somebody in our practice, but he was not real forthcoming about his comorbidities. But he has hypertension, GERD, benign prostatic hypertrophy, hyperlipidemia, anxiety, depression, and he smokes tobacco cigarettes. He was, it was the first time I met this guy, and he was a thin 64-year-old who looked older than 64. He was soft-spoken, and his affect was a little bit flat. I would describe him almost as downtrodden. But he was stable, and he was forthcoming with questions that I asked him. I didn't feel like he was forthcoming with offering a whole lot more than what I was trying to elicit. His UDS that day had benzodiazepines in it. We sent it for confirmation, and I can't remember if Ativan is one of those you have to specifically ask for. It did not come up in the confirmation. No benzos did in the confirmation, and but tramadol was in his confirmation, and he admitted that he had taken the tramadol that day, earlier that day. An interesting point, I didn't get too much into his pain with him. He doesn't really, that I know of, have any other mechanism for dealing with his chronic pain. And I didn't get into, has he done physical therapy? I just didn't get into the chronic pain. So if you could go back up to the top for me. So I thought this was for me, it was kind of a difficult situation, because I felt like the indication for Suboxone was really borderline, but I explained to him the complexities of everything, that he could not continue with the Ativan if we were to take buprenorphine. And I talked to him about the risks of suddenly stopping Ativan. And I also talked to him about I was not willing to have him I was not willing to prescribe buprenorphine if he was continuing on gabapentin. And so what we came down to was I agreed to start him on a low dose, 2 milligrams last Thursday. And he was going to tell his primary care provider that he was not taking the gabapentin and that he would stop prescribing it. He felt very confident that he could stop his Ativan, at least over the course of this week. And so then I said that I wanted him to feel that he was in care for his substance use disorder, which was what he was seeking. And he was very confident that he not only that he could participate in the requirements of our program. He didn't find the requirement for Form NA meetings a week daunting. I asked him how he found out about our program, and I can't remember what he told me. Somebody told him about our program, so it came recommended from somebody else, but I didn't get the details on that. So at any rate, and I didn't feel comfortable if he couldn't demonstrate, if it wasn't clear that he had stopped the benzodiazepines and the Neurontin, that I wouldn't feel comfortable continuing with Suboxone. So he is scheduled to have a behavioral health intake. Some of the gaps, and I've talked to the counselor, some of the gaps in what the history I got, she'll delve into further. Anyway, sort of an odd case. And I just wondered what people thought. Should I continue him?
Thank you so much, Jennifer. No, we really appreciate you submitting this case, and we're glad we have it. So does anybody have any clarifying questions? And I can always bring this back up. It's just easier for me to see everybody if I stop sharing.
Does he have a pain diagnosis?
I think he does. I don't have records from his PCP. When I asked him for more details on that, he just said, oh, I have pain all over. But I don't know what, and it was from work-related injuries. He's on disability related to that, but I don't have any details. And probably at this upcoming visit, I would have him sign for release from his primary care provider. But I believe it started with low back pain. And I don't know the diagnosis beyond that, if it's disc related or
If it's
musculoskeletal.
somatic pain or neuropathic pain, like the lancinating, radiating kind of pain, or the localized sort of aching pain.
I got the impression it was more localized aching, but I don't know that for a fact.
Okay.
He said I ache all over.
Thank you for your question, Dr. Hirschler. Does anybody else have any other questions?
It's not really a question, but a comment. You'd asked about like tramadol and like going from tramadol to Suboxone. Is that we had like a roundtable. I was in Vancouver a few weeks ago, and we did a roundtable with doctors from all over the world. It was pretty neat. And in Egypt, actually, tramadol is the #1 opioid that's abused in Egypt. So it's not so much fentanyl or heroin, but they have a huge problem with tramadol. So you absolutely can see a lot of tramadol abuse, and it's kind of interesting because it's actually in some ways similar to methadone in terms of some of the things it does, the neuropathic side. It's definitely just as abusable, and I'd say just as treatable with buprenorphine. So if you encounter people with tramadol problems, you probably will, and you might actually, if you have somebody perhaps from the Middle East or specifically Egypt, you might find somebody that has a tramadol problem. That's their primary concern. That's maybe all they've ever abused, and they could respond to buprenorphine. So it's just kind of a side thing,
That's really interesting, actually, and helpful, because I've just felt like, well, I'm just gonna, it helped him before when he was on Percocet. I'm gonna prescribe it again now, and then I'll ask, for counsel from you all. Angie Barker was out of town, and I just felt like it was okay for a week to give him that low dose and see what.
Yeah, it may do better with a higher dose even. That's. Yeah, it's not. It's a little bit of apples and oranges with the tramadol. You might also find, tramadol does some other things. Like it almost works as an antidepressant as well. So it has some. You can definitely cause serotonin syndrome with it. I'm blanking on how it does that. It's been a long day, but I'll think about it.
It's like a tricyclic, Jeremy. If you look at the structure, and it looks like a tricyclic antidepressant.
Well, I think it does that, but it's also a MAOI inhibitor, tramadol, if I'm not mistaken. So that's the other thing it can. Yeah. So it's you got to be a little careful with tramadol. So
interesting. I didn't know that. I think that this gentleman also will end up with a referral to psychiatry just for his anxiety and depression. And I did give him a low dose of Buspar the day I saw him, because the other reason I went slow on the buprenorphine was I was worried about the Ativan and just not knowing this guy. So anyway, and I just saw Nikki's comment in the chat, so thank you. And that reminds me, we did have a guy on Kratom about 4 years ago who we also used buprenorphine for. I had forgotten that. So anyway, that's very interesting about the tramadol. I appreciate all the comments on that.
One suggestion about analgesia with Suboxone is to have the patient divide the dose. That you get better analgesia if they take it in a TID kind of schedule instead of just once a day. So even the 2 milligram film can be broken up into 3 pieces and taken 3 times a day.
Oh, good. Okay, thank you. He didn't mention that he wanted it for pain, and I didn't, discuss that with him, but it seems that it could be of benefit.
Yeah, you can kill 2 birds with 1 stone.
Yeah. And I mean, I know you guys, it's my patient and it was my clinical situation, but you know, for somebody who says that they're not taking Ativan regularly and they think they can taper, you know, he did it before. I just felt like I was trusting him and what he was saying. And I gave him, you know, warning signs of, you know, if he was tapering too fast to contact us or go to the emergency room. But it all felt a little dicey to me. But I just was kind of trusting. He was so clear on what he felt was right for him that I just gave him my concerns and went with that. So that question was about people self-tapering their benzo.
Yeah, so 1 milligram TID is not a very large dose of Ativan. And if he's not even taking that, it might not be that hard to stop it, especially with the Buspar, and he has gabapentin if he had withdrawal, so he could, you know, use that. But you know, the thinking is that you don't want to not start Suboxone if somebody's on benzos, because the risk of using other opiates and benzos is much greater than using Suboxone and benzos.
Yeah, okay, great. Yeah, this is very helpful, thanks.
Thank you very much. Does anybody else have any comments or do you have any further questions? Yes, great case. Thank you, Katie.
I don't think I have any other questions.
Well, thank you so much. Really appreciate it. And we'll get that case back to you. All right, Olivia, are you ready? I have shared options for you to go ahead and share your screen when you're ready. Thank you so much.
All right. So I hope everybody can see my screen.
Yes, thank you.
Perfect. All right. So psychedelic assisted therapy. Kind of new. I'm sure you've heard things about it. Well, it's not really new. It's been around for a little bit. But it's starting to get a little bit more of a popularity and medical approach. So wanted to talk a little bit about it and the importance of it. So I don't have any disclosures. Whoops. Disclaimer, this is a really, really brief overview. I could do each part of the clinical process as well as each medication and multiple discussions. So it's a really brief overview of what this is. I'm going to talk about the 3 main medications, or kind of the front runners, and then just an overview of the clinical process, what that looks like, and what disorders each substance kind of works best with. So the 3 front runners, we have ketamine, which is legal and able to be used. It's a dissociative. We have psilocybin, which is your classical psychedelic. And then we also have MDMA, which is an empathogen. MDMA is probably the closest going through as far as schedules and getting that changed. Psilocybin in Oregon, they can go ahead and prescribe that, as well as Colorado. Couple places, it's probably going to be a while before it gets over here though. Ketamine. Ketamine is a little bit different than MDMA or psilocybin as far as the psychedelic assisted therapy and the treatment model, just because there are multiple different ways that it can be administered or taken. So it's a little bit more variable. Intramuscular and IV is going to be the most traditional and aligns most with the psychedelic assisted therapy model, which is preparatory sessions, screening and assessment, prep sessions, and then you do a medication session, integration sessions, medication, integration, 3 times. And so that's going to follow that. Oral and intranasal, theirs fluctuate depending on patient, a little bit with ketamine. It's got a different kind of bioavailability, which is like how it's actively absorbed in the body. So intramuscular and IV, as you can see, pretty good bioavailability rates, which means most of the active medication is available. Oral intranasal is rather low, which does not produce kind of some of those more mystical type experiences when looking at it for the psychedelic therapy. This graph, this shows kind of where each of those fall. So these bottom 3 are your oral, intranasal, and rapid dissolve oral. As you can see, they're kind of hovering around that 3.5 on the intensity rating, where the IM and the IV kind of peak a little higher. IM really is what produces those out-of-body, mystical, dissociative type experiences that really tend to be transformative. So ketamine has shown the best results for these, as well as treatment-resistant depression and chronic suicide ideations and anxiety, specifically associated around death. We have MDMA. MDMA, you can experience, it can be very, very broad. It can be simply just a mind-altering experience to a full-blown like ego dissolution. So dosing is a little bit different here. 75 milligrams to 125. That's going to be based on some stuff we'll talk about in this screening process, whereas you look at the previous experiences, how many previous experiences versus intention, and what you're wanting to get out of the session. And then there is an optional additional dose after 2 hours. That dose is going to be half of whatever that original dose is. So if someone got a 100 milligram dose, after 2 hours, it would be a 50 milligram dose, just to kind of prolong and intensify to really get those transformative, transcendental states. Like I was saying before, that treatment model, 3 prep sessions, 3 med sessions, and 9 integration. Those 3 prep are at the front, and then you have a medication session followed by 3 integration, and you do that for the 3 times. For ketamine, a typical session is 1 to 3 hours, depending. However, for MDMA, your typical session is going to be 6 to 8. Little window on either end. It could run a little longer depending on how sensitive you are. So MDMA has shown the most results for these specific disorders. They're doing a lot of studies with PTSD specifically, so that's where most of the research is right now. However, they're showing a lot of follow-up with substance use disorders, as well as those social anxiety in autistic individuals as kind of a follow-up. So this graph, it really is just looking kind of through each of the hours where those activation states are and those resting places are. Because MDMA does come in waves. You do have rest periods where things are not so active, and then it will peak back up again. And so just this kind of gives a little bit of overview of what that kind of looks like. And as it stands right now, this is through phase 2 of the MAPS study. 67% of patients are not qualifying for a PTSD diagnosis after one treatment round. And 88% of those patients are stating that they experienced a clinically meaningful reduction in their symptoms, which is really awesome. And right now they're going into phase 3. And when we had Rick Doblin come speak in the program that I attended, he was talking about how they're going to publish it soon, but it's over 50% of that 67% still no longer meet that qualifying PTSD diagnosis after a year. So they're getting into more longitudinal results now, which is nice. Psilocybin. Psilocybin, it has the same kind of treatment model: 3 prep sessions, med sessions, integration, dosing. So dosing is the most variable thing right now, because they're still trying to figure out, what dosing is going to work better for which substances or for which disorders. And so it ranges. They have the 10 milligram and the 20 milligram and 30 milligram capsule, but they've been also they have a 25 milligram as well as a 40. They haven't done much above 40 milligrams, but that is kind of variable still. For duration, this is going to be your longest duration session at 8 to 12 hours. And so when thinking about that, making sure that you're planning breaks as the provider is really important. These are sessions that are usually done with 2 people, so that there is that availability to be able to have some breaks and such. Right now, they're showing the best results for OCD and substance use disorder for psilocybin, which is awesome. They've also had a lot of really good results with eating disorders and psilocybin and sustaining change. So hopefully this will move quick. Looking at the process, so screening is incredibly important. Screening and the assessment process with screening, incredibly important, as well as intake. Intake is really not as important as the screening, but it does give you a lot of time and a lot of information to be able to put into the prep, the journey, and the integration. So when screening, your main purpose is the inclusion-exclusion criteria. There is really quite a bit of exclusion-inclusion, which I have a slide about in just a minute. But what you want to look at with that screening is getting all of those assessments done. You want to look at getting records from other behavioral health professionals or seeing whether that be psychiatry, if they see an outside therapist, and doing any kind of like questionnaires that you may find helpful in being able to like help guide them through this process as much as possible. So intake, you have your main information, kind of the standards. The additional information that you want to include here is that prior psychedelic experience. Was there challenging moments? Did you have an adverse reaction? You know, if you did have an adverse reaction, what was that? What did that look like? Because they may call it quote unquote a bad trip. However, we don't really look at it like that. We look at those more as challenging experiences that could still have meaning and can still provide a space of learning for the client. So really getting details about that, as well as a ride home, and to the sessions for obvious reasons. So exclusion criteria, like I said, it's a little bit lengthy. Some of these are going to be a little bit more fluid and less concrete. So the one that I talk about the most as being a little bit fluid is that uncontrolled hypertension. You know, they can come in, have uncontrolled hypertension, go see PCP, right? Start getting that under control. And then at that point, it's no longer uncontrolled. Some of these are a little less, any cardiac disease of any kind is an automatic exclusion just because of the risk associated. And something that you really also want to look at is that ocular surgery and any kind of like nope, not even gonna try intracranial stuff, because those really are gonna play a large impact in how things play out, just because of the elevated blood pressure that these can cause and induce. So prep is probably the most important part of the entire process, and it's where you spend a lot of information. You give a lot of information, you spend a lot of time there. Most of the time it says 3 prep sessions. However, those are usually 2-hour sessions. So 6 hours is usually spent on prep. And you can break those up a little more if you want, but a lot of time is spent prepping yourself as well as the client for what's going to happen, so that that journey is meaningful. Just kind of going through, right, the purpose, which I was already kind of talking about, is really the big thing here is discussing side effects, what to expect, and building that trust and support between you and the client, so that when they're going through the journey and when you guys are in that experience, there's comfort and the ability to kind of let those guards down, and not have so much fear with it. So when looking at what types of things are really important to address, as well as kind of the logistics, we really want to manage those hopes and fears with those expectations, what to expect. That way they're not going into this with this very unrealistic expectation kind of thing. You want to be very direct about what may or may not happen. You know, looking at all of that, you also want to look at the potential blocks that they can have, such as minimizing kind of the experience itself. And so really looking at normalizing what they're going to experience, focusing on feelings versus content, and then really kind of pulling in that what we call a beginner's mind, which is kind of approaching it with curiosity rather than this should have happened. And so the last one is dysregulation. And so one of the other things we really want to focus on during those prep sessions are, you know, how do we ground yourself so that you're not overly anxious when going into this, with breathing techniques, imagery stuff, sensory things. We also kind of approach this with allowing and encouraging patients to bring in different home objects that may be really comforting. A lot of people use like weighted blankets from home, pictures. If you have like crystals, rocks, things like that that are really important to you and really comforting, bringing those in so that you can have those with you. Oops. All right, and then another part of that is pre and post medication session and what that's going to look like. So just logistics of going through all of that. Really important piece here is looking at obviously the transportation, but then also the environment that they're going to be going home to and what they should and shouldn't have in that environment. So when coming out of a psychedelic experience, you're really kind of raw emotionally, really in touch and connected to emotions in a way that you typically may not be. And so you're going to be very sensitive to those things that are in the environment and happening around you, nonverbals, things like that. So you really want to have low stimulation, no big life decisions immediately afterwards, kind of low key, not necessarily sleeping, but just very calm and mild, maybe not around a lot of people, things like that. So I want to kind of touch base on this kind of term, spiritual emergency. You know, it was coined in the 80s by Stan and Christina Groff, and it's kind of specifically there and refers to a messy spiritual experience that may have some aspects of psychosis, but is not indicative of a long-term mental illness. And so when looking at spiritual emergency versus actual psychosis, what some of those differences are, and things to help recognize the difference in the two, a couple big things to look for. So a spiritual emergence is a gradual unfolding of transpersonal experiences. When that unfolding happens at a process or a rate that's too fast, or it becomes too intense or chaotic, then that can turn into what we call a spiritual emergency. Those things that indicate that it's not psychosis are that a spiritual emergency tends to present with higher daily functioning and not so much of an impact on that daily functioning, as well as an element of openness, curiosity to what's happening, and progressiveness. So as the clinician in the space, you really want to prepare yourself logistically as well as personally. So you want to be aware of your liabilities, what is permitted within your state, what are those ethical considerations, because it is a non-ordinary state of consciousness. Being very aware of those things, seeking consultation, supervision, things like that, as well as your boundaries, being well aware of those boundaries physically as well as wellness, right? How are you supporting you to be able to hold the space for the client as they're experiencing and going through what they're going through? What are your personal beliefs, and how are you going to put that kind of to the back burner? Because these are things that are brought up that can be a little bit in your face when you are in that moment. And so really making sure you're thinking about that. And self-doubt, because everyone has it. When you do kind of get into that, what can you do to kind of help just make yourself a little more at ease, right? So develop those checklists, protocols, structures, look at what are some of those complementary modalities, such as like somatics or internal family systems, mindfulness, things like that, that are really gonna pair well with the focus of psychedelic assisted therapy. And then remembering to also, right, bring that element of self-compassion, because you are human. It's not gonna go perfect. Nothing ever does. And to remember that, give yourself a little bit of grace in those moments when it's challenging. So this is a quote by Kylia Taylor, that she's a licensed family marriage therapist, and she has been working with non-ordinary states of consciousness for about 30 years. But I really like this because it reminds us that, number one, ethics, they require just extra attention, extra focus, but also professional self-reflection, and making sure that we're taking care of ourselves so that we can show up in the way that the clients need us, and that is ethical, and that is part of the taking special considerations for ethics with this non-ordinary state of consciousness. This was just a quote that I really liked. when thinking about traditional approaches to healing trauma, we're only using about 12% of our brain, and that's our conscious self. And so really that part is responsible for short-term memory, analytical thinking, rational thoughts, and being able to access that subconscious is where those parts that house your long-term memory, assumptions, beliefs, associations, reactive emotional motivators, that subconscious is where all of those are held. And so being able to access that subconscious to change those parts where all of those things are housed and create those different associations is really a powerful way to approach that part of healing. So set and setting, it's a really important part of the prep process, just because it frames kind of the getting to the journey and impacts a lot. It'll have a direct impact on how that journey takes place. So when looking at set, that's kind of the mindset of both clinician and practitioner. It goes back to that beginner's mind kind of approach and go into things with openness, curiosity, and just trust in the process. Setting is obviously the physical environment. When looking at that, this isn't going to be done in a traditional like hospital type setting. It's going to be better suited for more of a living room type setting with low lighting. There's music that is involved, mostly really promoting that comfort and safety piece in a relaxing environment. So like I said, music is a part of it. It is optional for music and eye shades. However, really, really encouraged, just because it does help limit kind of the interaction with that external stimuli. So keep it low. Music, not something that the client is going to pick out or bring with them. So what we do is there's a pre-selected kind of music thing. I can't think of the word right, playlist. There we go. So pre-selected music playlist, not a lot of words, very, very instrument driven, but it's also put together specifically for the journey itself. And so you're going to have some quiet, more tranquil stuff at the beginning and end to kind of taper in and taper out. And then you're going to have that active, more dramatic music in the middle. The actual medication sessions. So as a clinician, it can be really hard because your role is to basically sit there. When I was doing my training, this was so difficult. I did not realize how difficult it was to just sit and hold space until I had to do it. And so it takes practice, takes a lot of just reminding yourself to be present and to just hold that space, provide support. Write down different observations. If you notice that your client has gotten very quiet and their breathing has started to get a little bit more rapid, they're probably experiencing something challenging or a little bit more difficult for them. And so just a simple, hey, I'm here if you need something, might be what they need in that moment, just to kind of remind them like, okay, I'm all right, I can lean into this. And just taking little notes about things like that. If they randomly yell out words or phrases or sentences. They probably won't make any sense to you, but it will make sense to them later. For the client, they need to get comfortable, kind of just remember to embrace self-compassion and to tune into that inner healer and to approach it with the beginner's mind, right? That openness and that curiosity. But these are some of the things that you will see, right? They're going to be really attuned to those nonverbals. Emotions are going to be excessively intense and potential mystical experiences. Integration, it's really about taking the lessons, the insights, feelings, and experiences from the medication session and translating them into actions, habits, behaviors, and beliefs that'll carry through for the rest of their life. So when looking at integration, these are some of the goals. There's kind of two ways to get that. You have the ACE model, which is accept, connect, and embody. And then you have the PEM's energy system model, which is looking at the physical, emotional, mental, and spiritual and putting them together. In session, this is kind of what it's going to look like. There's going to be putting that experience into words, being able to put those feelings into words, and then taking them back in the body, taking kind of control of those again and looking at what are you going to do with that? You know, what things can we put into place to really help make this experience last, be long-standing. And then kind of that stabilization part where things are kind of leveling out, not so much in that window of neuroplasticity anymore, but things are kind of, now we're looking at the long-term goals, things are kind of more calm. Looking at follow-up and support. And so this is a little bit different than traditional therapy because we're seeing them for the specific treatment and you may not be staying long-term with that client after you do those integration sessions. And so really providing resources, there's online support groups, making sure that they have your phone number, you know, email, contact messages, things like that, whatever you find works well for you for them to get into contact if they do want to do follow-up sessions and things like that.
Hi, my name is Amanda. I am 41. I did the psychedelic assisted therapy January 7th of 2021. Little backstory, I was on drugs since I've been 14, and I'll be 42 this year. For a really long time, I did rehab, inpatient, outpatient, the program, 12 steps, and they worked for the time being. But there was always something else, like, that was more of an outside fix for me. It's, you know, the inner work that I was avoiding. So I had heard about the psychedelic therapy and I didn't know how I felt about it at first because, you know, I am in recovery and I thought, oh, you know, is that considered using? And so I did a lot of research on it and just little synchronicity started happening to where it was like I really felt called to to do that journey. And January 7th, I did. So, I did that. It was very intense. It was emotional. I feel like I probably shed, I'm not even exaggerating, probably 5 to 10 years of therapy and trauma. Like, I dealt with and like face front and center, which is what, you know, what we're all trying to avoid. It was very emotional, but it was also the most beautiful day of my life. It was the best. Like, I compare it to, so the day you have your baby. I have 3 kids, so you think, oh, nothing could ever beat that day ever. And I mean, not that it did, but when I had my children, that was the day I felt true love for someone else, like real love. When I did the journey, that is the day I really actually was like, wow, like, hi, my name is.
So that kind of messed up, but that was the day that she figured out that she really loved herself, is what she was going to say. That is a friend of a friend, and she found out that I was certified and wanted to send me a video about her experience. And so that's why I put it in here, just to kind of, I did ask, she was okay with it. And so that was kind of the end of my presentation. I have reference slides and question slides, but since the video messed up, I just go ahead and cut over here. Sorry, I didn't leave any time for questions.
Thank you so much. We could always, tackle this again in the future. Of course, it's, probably very new, at least new to my understanding. And it's nice to be open-minded to different types of methods that might work for different types of people. So I really appreciate you bringing that topic up. Olivia, does anybody have any comments or questions?
I was just thinking about what the mechanism of this might be. And I was kind of thinking it's sort of like a new equilibrium is achieved. And so you destabilize into this wild experience and then kind of develop a new equilibrium. Is that right, Olivia? Is that what you're understanding?
Yeah. It's opening up to different ways of experiencing the past and what you've been through. But yes, in a nutshell, yeah, in a controlled kind of environment with the support and, things in place that allow you to kind of understand the chaos that you're or that wild unknown that you're going into with the experience.
Thank you, Dr. Hirschler. Anybody else? Does someone do more than one session? A lot of times, like many sessions, or?
So it's usually 1 to 3. It depends on the person. The model is set for 3. However, it's not going to require that you do 3.
Perfect. All right, thank you so much. And yes, please pass us along some questions if you have them, and we will try and tackle this again. We just have a short poll. I know we're a little over time. I'm just going to put it up there if that's okay. And then our next time we will be meeting will be on July 10th with Mark Garofoli discussing Just Say No for 2023. So thank you guys so much. And we look forward to seeing you guys in the future.